Thanks, Dr. Gleave. Good morning, everybody. Thank you for the opportunity to speak today regarding my topic, which is novel therapies for BCG-unresponsive bladder cancer. Recently, I've had a few comments from the theatre staff about having difficulty understanding my accent, so my Kiwi accent, so hopefully that's not an issue for everybody during this talk. So my learning objectives today to review BCG, secondly to review novel therapies, and then focusing on their mechanism of action, their efficacy, as well as their relative toxicity. And lastly, I'd like to touch on future directions for non-muscle invasive bladder cancer therapies. So most of us are familiar with the AUA risk stratification for non-muscle invasive bladder cancer, and that ranges from low risk all the way through to high risk. And this stratification is important because it allows us to predict or prognosis for patients. So low risk patients, which are composed of those low grade disease, solitary, less than 3 centimeters, and pun lump, have a reasonable rate of recurrence, but a very low rate of progression. And that ranges up to high risk disease, where patients have a much higher rate of progression of approximately 50% over 15 years. And these patients are typically the high-grade ones, high-grade T1, high-grade TA, larger high-grade TA lesions, CIS, BCG failure patients, which we'll focus on today, variant pathology, lymphovascular invasions. So what is the current landscape for high-risk non-muscle invasive bladder cancer? So this is a sort of a picture I've generated. So generally those patients with TA or CIS or T1 would newly diagnosed would undergo a course of BCG. Then if they've had a recurrence, usually they would undergo a second course of BCG. And we'll talk about what an adequate course of BCG is considered in the next few slides. And those in specialist oncological centres, typically those patients with TA or CIS disease would be considered for other salvage therapies. However, those with T1 disease would be more suited to proceeding to cystectomy. So in terms of BCG, it's been around for many years. In fact, this is one of the first papers in 1976. So it's been around for over 40 years, and it has formed one of the cornerstone treatments for non-muscle invasive bladder cancer, and it still is one of the first-line treatments, as you'd all be aware. So BCG is pro-inflammatory, which is the inflammatory pathway, predominantly through the Th1 pathway, including cytokines, interferon gamma, and tumor necrosis factor alpha, although the exact mechanism is unknown. Goes through the innate immunity pathway, through natural killer cells and neutrophils. And it is actually a very effective agent, and multiple trials have demonstrated that it's been proven to reduce recurrence and progression in non-muscle invasive bladder cancer. However, unfortunately, it does have a adverse side effect profile, and these range all the way from mild local side effects such as irritative urinary symptoms of frequency, urgency, and hematuria, all the way to more systemic and significant side effects such as contracted bladder or ureteric obstruction or contracture, all the way through to systemic sepsis. And these side effects affect patients' tolerability and ability to withstand the BCG treatment. Also recently, there's been issues with BCG shortages, and this has led to several trials evaluating different BCG dosages. And lastly, unfortunately, some patients simply fail BCG treatment, and this is what the term BCG failure has been thrown around as. So the term BCG failure has been around for several years now, and people's understanding of the term can be fairly varied. So I've tried to show you in a diagram here of the various terms that have been thrown around. So BCG failure can be thought of as including those patients who have been BCG exposed or experienced. And I'd like to think of those patients who have had a degree of dosages of BCG, for example, an induction course of BCG. There's those patients who are truly BCG refractory, and those patients are, if they've had high-grade TA or CIS after induction BCG and a dose of and some maintenance, their first round of maintenance, or a second dose of induction BCG. If they've had high-grade T1 after, they can have had BCG refractory disease if they've had high-grade T1 after induction alone. And next, there's the BCG relapsing, which I've divided into early relapse and late relapse. And those patients who have had early relapse are those who have had a complete response and then get recurrence within 6 months for TA or T1 and within 12 months for CIS. And that's after adequate BCG treatment. And what I mean by adequate BCG treatment is they have had to have a 5 out of 6 doses on their initial induction cycle, and then 2 out of 3 doses on their first maintenance, or 2 out of 6 of their reinduction dose. So that's what we'll try and repeat that through the talk so that everybody understands what an adequate BCG course is. And then those who have had BCG refractory disease and early relapse are considered to have BCG-unresponsive disease. And those are the patients that are unlikely to benefit from BCG and candidates for further treatment options. So why does it matter if you get BCG failure? Well, unfortunately, there are high rates of progression and metastasis, up to 50% in those patients who have failed BCG or have unresponsive BCG. And this is a graph shown in the Uro-Oncology back in 2009, which shows a reduced survival in those patients who do not have a complete response to BCG. So currently, the gold standard for these patients is to proceed with cystectomy. But as we all know, cystectomy can be a fairly morbid procedure with mortality, especially in elderly patients with comorbidities. So there's definitely a need for novel treatments which are less invasive and morbid than cystectomy for these patients. So the AUA guidelines suggest that in a patient with persistent or recurrent intermediate or high-risk non-muscle invasive bladder cancer within 12 months of completion of adequate BCG, so just to reiterate, adequate BCG is considered a 5 out of 6 doses of an induction, and then 2 out of 3 doses of a first maintenance, or alternatively 2 out of 6 of a secondary induction. And if they're unfit or unwilling to cystectomy, a clinician may offer trial enrollment or alternative intravesical therapies. That may be valrubicin, gemcitabine, dosi, or combination therapies. They may also consider systemic immunotherapy with pembrolizumab to a patient. So in terms of what's currently used for these patients, valrubicin was until recently the only FDA-approved medication. It's got a 21% complete response in CIS and 8% disease-free at 30 months. Docetaxel has been used, which has got a 25% disease-free at 3 years, and gemcitabine at 19% at 2 years. And you can see in this graph here that the fall-off for successful treatment is fairly steep. This is actually for gemcitabine, leading to the 21% 2-year survival rate. So clearly, this isn't good enough, and we need better treatment options. Fortunately, there's a lot of trials on the horizon, and there's various agents that are in development. So I'd like to divide my talk into those different sort of groups, which were intravesical chemotherapies, device-assisted delivery, checkpoint immunotherapy, viral and gene therapy, and lastly, targeted therapies. So starting with the intravesical chemotherapies, So the first one I'd like to discuss is the combination of cabazitaxel, gemcitabine, and cisplatin. This is in a phase 1 trial for patients who are BCG exposed. So these are patients not strictly BCG unresponsive. They've only had one induction course. They've been patients who've declined or were ineligible for cystectomy. So these patients had a 6-week induction dose of carbazi, gemcitabine, and cisplatin. They had a post-TURBT post-induction TURBT and urinary cytology. And then those patients who had partial or complete response went on to have maintenance carbazi and gemcitabine monthly for year 1 and then bi-monthly for year 2. So as this was a phase 1 study, it was reasonably small with 18 patients. The mean age was 71 and median follow-up was 27 months. 6 patients had T1 disease and 13 had CIS. There were no dose-limiting toxicities. And although this was very small, it had promising initial results with an initial complete response of 94% and then 1-year recurrence-free and 2-year recurrence-free survival of 83% and 64% respectively. So another combination that we're all more familiar with, as it's used locally here in Vancouver as a salvage treatment, is gemcitabine and docetaxel. So generally that involves patient coming in and getting 1 gram of gemcitabine intravesikally for approximately 60 minutes and 50 to 100 mils of saline, and then a subsequent docetaxel dose sequentially, 37.5 milligrams and 50 mils of saline, and they're meant to hold this for 60 to 90 minutes. So this is a multi-institutional, the largest trial I could find, multi-institutional retrospective trial study from 2009 to 2018. It was in various centres through the States, and there were varying protocols. Some used, for example, urinary alkalization. Some places used chemo-hyperthermia. And they had 276 patients with a median age of 73 and a median follow-up of 23 months. Like the other studies, not all the patients were strictly BCG unresponsive. They were mostly BCG exposed, and 38% of the cohort were strictly, by definition, BCG unresponsive. And so you can see here the survival rates. This is the overall survival rates for all patients, which was 46% at 2 years, bladder recurrence-free survival, and 52% for high-grade recurrence-free survival. And so 15.6% of these patients ended up having a cystectomy at a median of 11.3 months post-induction. And most patients remained T1. However, there were 11 patients that had upstaging to T2 disease. And unfortunately, 5 patients ended up having lymph node positive disease. So they may have missed the boat for curative treatment option. The treatment was tolerated reasonably well. 40% developed symptoms, but only 3% dropped out. There were 13 of the 44 deaths that occurred were due to bladder cancer, and had a follow-up of 23 months. 8 of these patients initially had CIS, and the rest had a mixture of the other combinations. So the bladder cancer-specific mortality was 1% at 1 year and 4% at 2 years, compared to the all-cause mortality of 3% at 1 year and 13% at 2 years. So this was a retrospective. The problems with the study was it was a retrospective study, and the populations were fairly heterogeneous in terms of disease stage and BCG, previous BCG therapy. And on the right, there's a survival graph for those patients who had BCG unresponsive disease, and it shows a 52% recurrence-free at 2 years for those who have papillary disease, compared to 50% in CIS. And that's a recurring theme, is those patients who have CIS disease have a lower recurrence-free survival, possibly because the papillary lesions are resected. So there's an element of surgical treatment, whereas the CIS is being managed by the intravesical treatment. So now I'd like to move on to device-assisted delivery systems. So the first one I'd like to discuss is chemo-hyperthermia, and this was discussed in the HIM trial, which was out of European Urology. So what this involves is heating the inside of the bladder up to the intravesical treatment in the bladder. So with mitomycin, with the HIM trial, they did 2 cycles of mitomycin and heated the mitomycin up to 42 degrees. So they initially installed 20 milligrams of mitomycin and heated it up to 42, and then they drained it and then installed another 20 in the subsequent 30 minutes. And that's thought to work by improving the delivery of the chemotherapeutic agent to the bladder wall by inducing opening microtubule assembly within the bladder wall. So that improves delivery of the chemotherapy agent to the bladder and the dose. So the HIM trial was a phase 3 randomized trial comparing mitomycin versus standard BCG. So in the mitomycin arm, they had a 6-week induction course followed by 6 weekly doses for the first year and then 8 weekly doses for the second year. The BCG protocol followed the standard SWOG trial protocol, and it was for unresponsive non-muscle invasive bladder cancer. They were randomized after stratification for CIS status and previous BCG exposure, and the primary outcome was complete response for CIS and disease-free survival for all patients. They acquired 104 patients, with 48 in the right arm versus 56 in the control arm. So they found no significant difference in the disease-free survival. There was no difference in 3-month complete response rate in CIS patients. The disease-free, interestingly, they did find the disease-free survival was significantly lower in the right than the control group in those who had CIS. So this finding, which you can see in the bottom left curve, has led to the premature closure of the study. They found disease progression in 4 patients in each arm, and the adverse effects were comparable in both groups. Now moving on to electromotive treatments. So this is where an anode catheter is applied into the bladder, and 2 catheters applied suprapubically, and this allows an electrical current to induce a directional and accelerated movement of the ionized drug towards the tissue. And once again, this is designed to improve the local therapeutic effect and increase its effectiveness. So this is a trial out of BMC cancer. And in this trial, there's a phase 2 study with 36-month follow-up in 26 patients who are BCG exposed. So this wasn't, once again, BCG unresponsive disease strictly. They had 1 induction course. They applied 40 milligrams of mitomycin in 100 mils of water, and they retained in bladder for 30 minutes with 20 milliamps of pulsed electric current. They did induction 6 weekly, then monthly for 6 months. And they did follow-up systematic mapping biopsies of the bladder, prostate with cytology and imaging. So in terms of their disease-free rate, it was 75% for those with, approximately 70 to 75% with those with TA or T1 disease. This dropped off to 50% for those with CIS disease and 25% with combination. Out of the 26 patients in the trial, 10 patients ended up having cystectomy, with 4 upstaging to T2 and 6 with high-grade T1. 16 patients managed to preserve their bladder during their follow-up. There were adverse systemic events of hypersensitivity in 3 patients and local side effects in 26.1% of patients. And so I thought this is another study looking at it. This is a fairly small study, but it was done locally in Canada, so that's why I thought it'd be relevant to include. It's done by the team in Toronto, published in Urological Oncology just last year. So in their study, they actually combined EMDA with BCG. So they had their induction course involved alternative doses of EMDA mitomycin with BCG treatment. That was a retrospective review with median follow-up of 870 days with 26 patients. 22 were BCG unresponsive, 4 were BCG exposed, and the population, just over half of the patients had CIS. In terms of their side effects, 19% had hematuria, dysuria, and 12% had frequency. 3 patients ended up having to be admitted with fever and ended up getting antibiotic treatment. And as you can see in the curves, there was a fairly steep drop-off in terms of recurrence-free survival for these patients. Next, I'd like to go on to checkpoint immunotherapy. So most of us are familiar with the mechanism of action for these treatment options, but just to review things, there's a PD-L1 ligand of the tumor cells and PD-1 of the T cells, and usually this interaction between these receptors acts as an immunoregulatory mechanism in order to reduce the natural immunity from killing off the tumor cells. And so the idea with these PD-L1 and PD-1 blockers are to inhibit this regulatory pathway to allow natural immunity of the T cells to kill off the tumor cells. So the key paper looking at pembrolizumab was Keynote 057, and this actually led to FDA approval for pembrolizumab, for systemic pembrolizumab for BCG unresponsive disease. This was presented at ASCO this year, and it's also led to Health Canada approval, but it's not currently covered. So in this paper, they have so far looked at cohort A, which is BCG unresponsive disease with CIS plus or minus papillary disease. These patients were ineligible for or declined to undergo cystectomy, but my understanding is that most of the patients had actually were candidates for cystectomy, but for one reason or another declined to undergo this treatment. The patients, the endpoint was complete response. The primary endpoint was complete response. Secondary endpoints were duration of response, progression-free survival, overall survival, and safety. The patients had 200 milligrams of intravenous pembrolizumab given 3 weekly, and they were assessed at 12 weeks and assessed again at the 24-week mark. Those patients that didn't have any evidence of recurrence or progression went on to continue the pembrolizumab for up to 2 years with regular efficacy assessments through to year 5, or until they get recurrent or progressive disease. Those patients who developed progressive disease were discontinued treatment and entered up into survival follow-up. So in this paper, they had 96 patients, and the key number here is 41% had complete response at a median follow-up of 36 months. So this is one of the graphs in the paper in the presentation, but as you can see, it's fairly misleading because on the y-axis you can see the number 100, but this 100% is actually of the 41% complete responders. So really at the top of the total cohort, it should be 41%. And so you can see on the survival curve that at 6 months, they had a 31% complete response, and at 12 months, it was down at 20% complete response. And in terms of the duration, median duration was 16.2 months, and 46% of the responders had a complete response duration of over 12 months. 42% of the patients ended up having a cystectomy, and 3 of these patients ended up having muscle-invasive disease. As you would expect with any systemic treatment, they did have a reasonable amount of side effects. So 96% had some degree of treatment-related side effect. 13% ended up having grade 3 or 4 treatment-related adverse effects, and 8% had to stop treatment due to adverse effects. And next one I'd like to discuss is atezolizumab, which is a PD-L1 inhibitor, and this is a paper with actually Dr. Blacks as a first author, which is the SWOG 1605 trial. So this study involved those patients with BCG refractory or BCG intolerant disease. They had initial TURBT and went on to have 3 weekly atezolizumab with a cystoscopy and cytology at week 13. They continued on their 3 weekly treatment, and the key here is that they all had a mandatory cystoscopy and biopsy at the 6-month mark. They continued on their atezolizumab and went on for surveillance for 18 months. So at USCO, they reported their subset of patients with CIS. They had 73 patients with a median age of 73 years. Their median number of previous BCG doses was 12. They had concomitant Ta/T1 tumor in 41%, and their complete response at 3 months was 41% and 26% at 6 months. Once again, given this is a systemic treatment option, they did have side effects. And the ones to highlight, so 16% of patients had grade 3 or 4 treatment related adverse effects, and 1 patient actually died, and this was related to, I think, myasthenia gravis with respiratory depression. So now I'd like to move on to viral and gene therapy. So first agent I'd like to discuss is nadofaragene. So nadofaragene is a non-replicating adenovirus with the interferon alpha-2b gene installed into the recombined into the virus, and it's given in addition to SYN3, which is a surfactant. So the agent is given intravesically into the bladder. The SYN3 helps with the uptake of the agent into the bladder tumor cells. So the virus is incorporated into the nucleus of the cells, where it is incorporated into the gene and produces the protein interferon alpha-2b, and this protein helps with causes cytotoxicity to the tumor cells with apoptosis, anti-proliferation, and anti-angiogenesis. So this is similar to the intravesical interferon. However, this treatment would last for several weeks, as opposed to the intravesical treatment, which would only last for a couple of hours. So it essentially increases the exposure time of the interferon to the bladder cancer. So this drug is currently under FDA review. So this is a phase 3 study published in the Lancet, actually, and they had 157 patients enrolled. Most of the patients, 107, had CIS, and 50 patients had papillary tumors. So their patient population was high-grade BCG-unresponsive disease, 157 patients. they received the nadofaragene in addition to they received the nadofaragene intravesically every 3 months with a planned dwell time of 1 hour. The primary endpoint was complete response of CIS at any time after the first installation, with the key secondary endpoints as seen on the table there. So focusing in on the 103 patients who had CIS, they had a median follow-up of 19.7 months, and they achieved a 53.4% initial complete response. It's dropped down to 24% at the 12-month mark. Now bringing in those patients who had papillary disease, so they had a much higher, as you'd expect, initial response rate of 73%, dropping down to 43% at the 12-month mark, giving an overall initial response of approximately 59%, dropping down to 30% at the 12-month mark. And here are some graphs comparing the recurrence rate of those who had CIS compared to papillary lesions. So you can see the high-grade recurrence-free survival of CIS is lower compared to those who have initial TA or T1 disease. So the treatment was fairly well tolerated. 3 patients discontinued treatment. 26 patients went on to have cystectomy at 12 months, and 12% of these had T2 disease. There were no grade 4 or 5 treatment-related adverse effects. There were some patients ended up having grade 3 effects, but these were fairly rare. Most of the patients had grade 1 or 2. Of the adverse effects, most of them were grade 1 or grade 2. Now moving on to the CG-0070 agents. So this is another adenovirus, another agent based on the adenovirus with 2 main modifications. First one involves an E2F1A promoter, and this makes the agent makes it specially targeted towards bladder cancer cells which are deficient in the retinoblastoma tumor suppressor pathway. So the first modification, the E2F1A modification, improves the drug specificity. The other modification to the adenovirus is the installation of the granulocyte macrophage colony stimulating factor, and this enhances the immune reaction, which is instigated by the virus. So by that mechanism, it causes cytokine release, antigen release, and killing of the tumor cells. So CG-0070 is given weekly for 6 weeks and then 6 monthly until 18 months. In this phase 2 Bond 2 study, they had 67 patients and had a biopsy at 6 months. 11 patients had cystectomy, and 6 of these patients had T2 disease. So just looking at the population, there were 36 patients that ended up having CIS, and those patients had a 50% complete response rate. And the graph shows pretty similar response rates between the overall population compared to the CIS. And so initial response rate was 50% for CIS and 47% for overall, and this went down to 23 and 19% respectively for the overall and CIS groups. In terms of the toxicity, so most patients had, of the adverse effects, most of them were mild grade 1 to grade 3 effects. There were no grade 4 adverse effects, and there were 7% had deaths, but these were unrelated to the treatment. They were related to cardiac disease, esophageal cancer, urothelial disease progression, and lung cancer. And in the future, there's further phase 3 trials evaluating this agent and its combination with pembrolizumab in BCG-unresponsive treatment, BCG-unresponsive disease. So now moving on to targeted therapy. First agent is pertuzumab monatox. So this is a fusion protein consisting of a cytotoxic payload, which is Pseudomonas exotoxin A, and this is combined by a tether to an antibody fragment. So this tether is designed to stabilize the agent, and the antibody fragment attaches onto the EpCAM antigen, which is much more prevalent in cancer cells compared to non-cancer cells. So this aids in its specificity for the cancer cells as opposed to normal tissue. And this blocks protein synthesis, leading to tumor destruction. And then furthermore, it activates the immune system, relating to causing the T cell involvement as well. Sorry, I should say this drug is currently under FDA review. So this agent was reviewed in the VISTA phase 3 trial, where they applied bi-weekly induction doses for 6 weeks, followed by weekly dosing for 6 weeks. If a complete response was achieved, they had maintenance every other week dosing for 2 years. So it's a fairly intensive dosing regime. The complete response was 68% initially for those who had papillary disease, going down to 36% at the 12-month mark, and they had 36 patients in this arm. And in the CIS arm, as you'd expect, the response rate was lower at 39% initially at the 3-month mark, going down to 14% at the 12-month mark. And they had 88 patients in this arm. In terms of the durability, so the median duration of complete response was 227 days for those with CIS, and the median time to recurrence was 270 days for those who had papillary disease. 25% of patients ended up having cystectomy. Once again, the treatment-related side effects were mostly grade 1 and grade 2, composed of dysuria, hematuria, UTI, and there was 2% of grade 4 or grade 5 side effects. And finally is the N803.
So, Omid, can you go back? What was the primary endpoint of VISTA? Was that achieved? Go back one slide. Did this achieve the primary endpoint of the trial?
Of looking at complete response rate?
Yeah, what was the statistics behind the primary endpoint, and was it met? Because it's undergoing, I assume, an NDA review with FDA now. So what was this? I can't tell if this was, it's a randomized trial, phase 3. So what was the primary endpoint?
Complete response.
And the statistics behind that? I mean, so has this met its primary endpoint from a hazard reduction point of view and a p-value?
I couldn't tell you the exact, I mean, this paper I don't think was actually
I can jump in. It hasn't been published, just a paper. It's a single-arm trial, BCG unresponsive. They call it phase 3 just because there's a prior phase 2, so you can wonder about the terminology. The endpoint is all around the complete response rate and the 95% confidence interval that it excludes 20% at 6 months. And then the duration of response is sort of up to the FDA's judgment. And they've been fairly lenient, because if you look at the 12-month response here, you'd think it's relatively worthless and you wouldn't want to give it to your patients. But that part will be up to FDA to decide.
Okay, I see. Yeah. The yellow and the blue are different tumor states, conditions, not different treatment groups. Okay.
Yeah, those are the CIS is the blue and the yellow is the.
I mean, one would say that has a pretty small response rate in the group with the CIS. Yeah. Okay.
So the other targeted therapy is the N808, which is based on which is an interleukin-15 super agonist, and this leads to a proliferation and activation of the natural killer and cytotoxic CD8 cells without inducing a T cell regulatory pathway. So through this, in a basic sense, this agent works by putting the immune system into overdrive, and it works synergistically with BCG. So it's given with BCG at the same time. So in this QUILT study, phase 2, phase 3, they had histologically confirmed BCG-unresponsive disease with CIS in 80 patients. They gave BCG with the N803, 6-weekly induction, and then a single reinduction dose, or a single reinduction dose with maintenance. Their primary endpoint was complete response at any time, at any point. So one of the important things with this is that this population was very heavily treated. And so, as you can see, 59% had had previous chemotherapy, 3% had had previous checkpoint inhibitors, 13% had had interferon, and 3% had had vicinium. They had a follow-up of 10.7 months. So impressively, this agent had a complete response rate of 72%, which is the highest so far in all the agents I've presented. Of the patients who had a complete response, 59% of the patients managed to maintain this complete response for 12 months. And the median duration of the complete response was 19 months. So it's most efficacious in terms of the initial response, in terms of the anytime response, as well as the durability. The treatment was well tolerated with low-grade treatment-related adverse effects, including dysuria, hematuria, urgency, and spasms. 12.5% of patients proceeded to cystectomy in this BCG-unresponsive population. So good bladder preservation during the follow-up so far. So just because we've gone over so many different agents, here's a table summarizing all of it. So this is for patients who looking specifically at those patients with CIS, and the complete response is best in the best in N803, and the other agents are approximately 40 to 50%. The median duration of complete response was very favorable in N803, with a good cystectomy-free rate and a low toxicity rate. The other thing to outline is the number of dosages, which is important because that leads to burden for both the person administering the not only the person administering the dose, but the patient who has to keep coming in to get the dose. So if you compare N803, which 27 doses in 3 years, compared to, for example, otorozumab with 27 doses per year. So that's another important consideration to have when comparing these agents. So in terms of trial development, these are very heterogeneous populations. There's patients who, some of the trials had BCG-exposed patients, some had BCG-unresponsive, so it's important to define the patient population. Lots of them had different stages for high-risk disease, so it's important to stratify those between those who had T1 disease, high-grade TA, and CIS. As we know, the outcomes are different for these disease states. They have a lack of appropriate control group, and they were single-armed phase 3 studies. There's a question as to are we causing harm by delaying cystectomy in these patients? I don't think we can answer that question at this stage. And the other question is, are we providing any benefit in delaying cystectomy? And due to these difficulties, the FDA has provided a guidance in assisting novel drug development in 2018. So that's helpful. And most of the trials I've discussed go by the guidance provided by the FDA in that guideline group. So this table is out of a review paper we're currently submitting, showing that there are a lot of different trials currently underway looking at in this space. And if you look on the bottom right, there lots of these trials are actually combination treatments, which may be the future for looking at this condition. So on the horizon in Vancouver, Dr. Black let me know that there's a trial that we're going to start doing here in Vancouver, looking at photodynamic compounds. So this is ruthenium, based on ruthenium, which is a transition metal compound TLD144, and that's joined up with transferrin, which is a transporter, which is a molecular transporter, and that's joined up to form ruthenium. And so the importance of transferrin is that the tumor cells have an increased number of transferrin receptors compared to normal cells. So the transferrin provides specificity of this agent to the cancer cells, and this agent is then sensitive to light, which causes cytotoxicity through generation of reactive oxygen species to the tumor cells. So in a phase 1 study of only 6 patients, they found a response rate of 67%. So once you install the agent, you drain the bladder, and then you apply this green light. The green light is important in that it, from my understanding, it focuses on more superficial disease compared to going deep into the bladder and causing toxicity, which lots of the other photodynamic compounds have caused. So they have a light emitter and also a light detector, so you can control the dose administered into the bladder. So the trial will have 100 CIS BCG-unresponsive patients. It's multi-centered with 20 units in total, I think mostly in the United States, and it's currently open in Vancouver. And so moving on from BCG unresponsive, the disease, another question we have to address is, can we act sooner in the disease state? Can we change the natural history of this condition by acting in the BCG naive patients? And there is a variety of different trials currently underway looking at these different agents, and once again combinations in patients who are in the BCG naive state. So there'd be much more to come in this condition. In Vancouver, there's the CREST trial opening up, which is an anti-PD-1 antibody with BCG in high-risk muscle and non-muscle invasive bladder cancer, which are BCG naive. And the key thing for this agent is it's actually a subcutaneous agent, which will be much easier to administer compared to intravenous agents. So in conclusion, there are a variety of different promising new treatment options. We need ongoing long-term follow-up to determine durability of response and the impact it will have on patients long-term. One thing which I couldn't find much on is the biomarkers. So we need to know which patients would respond optimally to these intravesical agents, and which patients will not respond and need to proceed to early cystectomy. And finally, sequencing and combination trials will be the way of the future to try and improve drug efficacy. And so I'd like to thank Dr. Black for his help and guidance and talking and putting together this talk.